Hi everyone, my name is Insomnia Fitts and my presentation is about insomnia in the elderly. The objectives of this presentation is to discuss the importance of sleep and consequences of sleep deprivation, what is chronic insomnia, the definition, causes, and treatment, discuss sleep hygiene practices, and patient education regarding sleep. The importance of sleep. Sleeping is an essential human need. It plays a critical role in overall well-being and health. Sleep is involved in helping the brain function properly and helps protect mental health, physical health, quality of life, and safety. Sleep deficiency is a common health problem across the United States. So some consequences of sleep deprivation in the elderly population. It is associated with decreased memory, impaired concentration, and impaired functional performance. And in the elderly, sleep deprivation leads to an increased risk of accident, falls, and chronic fatigue. And it can also lead to an increased risk of depression, delirium, and mortality in the elderly population. Some interesting facts about insomnia. Insomnia is a very common complaint in the United States. A national survey found 35% of adults reported insomnia in the previous year, and half of them described it as serious. A systematic review of 50 studies found that around 10% of adults develop chronic insomnia with daytime consequences. Studies also show that women are 50% more likely to develop insomnia than men. Studies have found a correlation between insomnia and hypertension, myocardial infarctions, anxiety, depression, and diabetes. Important thing to remember is many patients do not complain of insomnia at their appointments, so it's important to ask questions related to sleep. The DSM-5 defines insomnia as dissatisfaction with sleep quantity or quality associated with one or more of the following symptoms: difficulty initiating sleep, difficulty maintaining sleep characterized by frequent awakenings or problems returning to sleep after awakenings, early morning awakening with an inability to return to sleep. An additional diagnostic criteria for insomnia includes the sleep disturbance causes clinically significant distress or impairments in social, occupational, educational, academic, behavioral, or other important areas of functioning. The sleep difficulty occurs at least 3 nights per week. The sleep difficulty is present for at least 3 months. And the sleep difficulty occurs despite adequate opportunity for sleep. There are many different factors that can be involved in sleep disruption and insomnia. Some examples include age, cognitive impairments, the response to stress, sleep-related beliefs, sleep habits, such as the daily sleep and activity cycle and napping, inappropriate light and noise exposure in the environment, mismatched bedroom temperature, disruptive schedules, having limited social interactions, partners' nightly or routine habits. There are some medications that can have direct effect on sleep or indirect effect on sleep. Some health-related sleep disruptors include pain, depression, nocturia, anxiety, dyspnea, heartburn, and cough. There are sleep disorders, which are sleep-related breathing disorders, sleep-related movement disorders, or circadian rhythm disorders. And then there's substance abuse, such as alcohol, tobacco, and caffeine. Insomnia is typically undertreated and non-pharmacologic interventions are underused by healthcare practitioners. The goal of therapy is to reduce morbidity and improve the quality of life for the patient. Making behavior and lifestyle changes can improve your overall sleep quality and help you fall asleep faster. These changes don't have the side effects that sleep medicines can cause, and the improvements can last longer over time. Making simple lifestyle changes may help you sleep better. Some examples of these include changing your sleep area or schedule, keeping a regular bedtime and wake times every day and trying not to nap during the day, avoiding big meals or too much fluid later in the evening, staying active, avoiding alcohol before bed, and doing relaxation exercises such as meditation or yoga. Cognitive behavioral therapy for insomnia is a type of therapy specifically used for insomnia. It can help improve your sleep patterns until you're able to get more quality sleep. One part of cognitive behavioral therapy is learning to have a good sleep hygiene, which includes getting rid of distractions in your room and keeping a consistent sleep schedule. You also focus on goals such as changing thoughts and behaviors that interfere with good sleep, creating a sleep schedule that gradually helps you sleep more over time. You can work with a therapist who helps you identify and change thoughts and behaviors that keep you from getting good sleep. There are also pharmacological options for people that have insomnia or sleep disturbances. Even if medications are being used, non-pharmacologic sleep hygiene interventions are still recommended to try to get the best quality sleep. So with a little background on the importance of sleep, chronic insomnia definition, causes, and treatment, now going to move forward to my case overview. My patient is an 80-year-old white female, Rita Johnson. She has been married to her husband for 61 years. They live independently at their home, but they do live right next door to their daughter, son-in-law, and 3 grandchildren. Rita's past medical history involves 2 normal vaginal deliveries in 1970 and 1972, a 15-year history of AFib, appendectomy in 1999, and basal cell carcinoma in 2018. Her current medications are metoprolol 25 milligrams twice a day, Coumadin based on her INRs, and Advil PM. Rita is a retired accountant and she receives Social Security as her monthly income. Further objective data regarding Rita's assessment include her vital signs, which were normal, blood pressure 128/76, heart rate 90, respiratory rate 16, SpO2 98% on room air, temperature 98.8. Her physical exam was great. She was alert and oriented ×4, well groomed. She did look tired and was yawning frequently. Her head was normocephalic, no known head trauma or injury, and no report of headaches. She wears glasses for reading. Her pupils were equal round and reactive to light and accommodation. Her ears, nose, and throat, no abnormalities. Cardiac rhythm was irregular, related to AFib. Heart rate 90, no edema or swelling. Her lungs were clear and equal to auscultation bilaterally. She reports a good appetite, denies any nausea and vomiting, and her last bowel movement was this morning. She denies any frequency, urgency, or burning with urination and reports no nocturia. Her abdomen was soft, non-tender, and bowel sounds were present in all 4 quads. Musculoskeletal, she moves all extremities well. Her gait was stable, 5 and 5 motor strength in all extremities. Her skin had some generalized dryness, but was all intact, no rashes. And psych reported being stressed and anxious, but overall pleasant. The American Academy of Sleep Medicine recommends the patient should complete a general medical psychiatric questionnaire to identify comorbid disorders, Complete the Epworth Sleepiness Scale or other sleepiness assessment to identify sleepy patients and comorbid disorders of sleepiness, and complete a 2-week sleep log to identify general patterns of sleep-wake times and day-to-day variability. Other testing, such as blood imaging studies or EKG, were not indicated as a routine assessment of chronic insomnia, unless there was a suspicion for comorbid conditions. Rita reports her medical conditions as AFib and seasonal allergies. Her current medications are metoprolol 25 milligrams twice a day, Coumadin per her INRs, and Advil PM for sleep. She reports no known drug allergies. Rita also denies any history or any current use of alcohol, tobacco, or illicit drugs. She also explains how she's unable to participate in exercise due to being so tired. Before this all started, she said she would go on morning walks with her husband and do water aerobics with some of her close friends. And she's currently not following a specific diet. Her family history. Her mom died at age 58 from breast cancer, and her older sister at age 60 from breast cancer. And her father died from a brain aneurysm at age 62. At this current time, Rita denies any depression or suicide ideation, but she does report increased anxiety and stress. Rita's chief complaint is, quote, "I can't sleep at night. When I go to bed, I lay there for hours and my mind is constantly going, and it doesn't stop," end quote. Her history of her present illness. Rita has had insomnia for about a year. It all started when her and Mr. Johnson's house was broken into one evening when they were at the grocery store. They came home and their house was a mess and valuable items were missing. Their son-in-law had a home security system installed soon after. Then a few months after the home burglary, Mr. Johnson had a heart attack and had surgery. Rita reports being unable to turn her brain off, feeling overwhelmed and stressed out about her husband's well-being. She complains of being exhausted all the time. She has been using Advil PM, but she reports that doesn't help much. Rita was seen over 4 months ago regarding insomnia, and she has followed through with the recommendations of keeping a sleep diary, darkening her bedroom, and avoiding daytime naps and caffeine. And she reports, quote, "I've tried all that crap and is not working. I need a sleeping pill. I have had Ambien before. Can you give me some more of those?" End quote. I do believe that Rita is experiencing chronic insomnia. And I agree that she needs a medication that will help her get to sleep and help her get a good night's quality sleep. It has been a year since she has been experiencing these symptoms, and over 4 months since she has implemented sleep hygiene interventions with no improvement. I would like to bring to the attention to Rita that the current medication she is using, Advil PM, and the medication that she has in mind, Ambien, are both not the best medications for her to be taking right now, because they are both listed on the Beers criteria. The American Geriatric Society Beers criteria includes a list of certain potentially inappropriate medications for older adults. Potentially inappropriate medications are treatments with risks that may outweigh the benefits. The AGS Beers criteria is based on the latest research. The AGS is a group of 6,000 healthcare professionals with expertise in caring for older adults. Advil PM, listed on the Beers criteria, puts older adults at an increased risk for gastrointestinal bleeding or peptic ulcer disease. Ambien has adverse effects similar to those of benzodiazepines in older adults, delirium, falls, fractures, increased emergency room visits / hospitalizations, motor vehicle crashes, minimal improvement in sleep latency and duration, which are why both of these would not be appropriate for Rita to be taking at this time. I would want Rita to continue to implement sleep hygiene interventions to maximize her quality of sleep. Some of the sleep hygiene recommendations I would make or have her continue are to avoid or minimize the use of caffeine, cigarettes, stimulants, alcohol, and other medications. If medically able, increase activity level in the afternoon or early evening by walking or exercising outdoors. Rita did report that she missed her walks with her husband and water aerobics with her friends, and by improving her sleep, she thinks she would be able to participate in these again. And that these activities would not only help improve her sleep, but also the anxiety and stress that she is experiencing. Some other recommendations would be to increase exposure to natural light and bright light during day and early evening. Avoid napping, particularly after 2 p.m. Limit naps to one nap of less than 30 minutes a day. Check the effects of medications on sleep. Rita and I did review this. She's currently taken metoprolol and Coumadin, and we do not believe that the medications are affecting her sleep at this time. Go to bed only when sleepy. Maintain comfortable temperature in room. Minimize light and noise exposure as much as possible. Avoid heavy meals at bedtime. Limit liquids in the evening. Try to keep a regular schedule by resting and retiring at the same time each day, and eating and exercising on a regular schedule. The stress management measures: tolerance of occasional sleeplessness, discuss worries and stressful events enough time before bedtime, and use relaxation techniques such as meditation or yoga. Another recommendation I would make to Rita would be participating in cognitive behavioral therapy. Cognitive behavioral therapy teaches you to recognize and change beliefs that affect your ability to sleep. This type of therapy can help you control or eliminate negative thoughts and worries that keep you awake. The behavioral part of CBT helps develop good sleep habits and avoid behaviors that keep you from sleeping well. The alternative medication option I would recommend for Rita would be Remeltion. It is used to treat insomnia associated with having trouble falling asleep. The mechanism of action: it's a melatonin receptor agonist with high affinity for MT1 and MT2 receptors. It works by affecting certain substances in your body that help regulate your sleep-wake cycle, metabolism, and excretion. Remeltion is extensively metabolized by the liver, mainly by CYP1A2 enzyme system. Metabolites are excreted mostly in the urine, and a small amount is excreted in the feces. The half-life is 1 to 2.6 hours. The dosage is 8 milligrams by mouth 30 minutes prior to bedtime. Adverse effects to watch for: behavior changes, dizziness, hallucinations, headache, and angioedema. If it works, Remeltion can reduce the time to sleep onset, increase total sleep time, and may improve quality of sleep. If insomnia doesn't improve after 7 to 10 days, contact your PCP to discuss other pharmacologic options and continue working on improving sleep hygiene interventions. I would want to provide Rita with some important teaching points before sending her home. I would explain to her that as we age, we often experience normal changes in our sleeping patterns, such as becoming sleepy earlier, waking up earlier, or experiencing less deep sleep. However, disturbed sleep, waking up tired every day, and other symptoms of insomnia are not a normal part of aging. Sleep is just as important to your physical and emotional health as it was when you were younger. I would explain to Rita the benefits of implementation of sleep hygiene interventions in CBT in combination with her new medication, Remeltion. I would instruct her to take the medication as directed within 30 minutes of going to bed and to confine activities to those necessary to prepare for bed. I would make her aware that this medication can cause drowsiness, so I would caution patient to avoid driving and other activities requiring alertness until the response to the medication is known. The actions at melatonin receptors can carry over to the next day and could potentially cause daytime sedation, fatigue, and sluggishness. But this is not common with Remeltion. Remeltion has not been associated with impaired balance, mobility, or memory. I would let Rita know there is no abuse potential for Remeltion. And I would also make her aware to not administer with or immediately after a high-fat meal, as this could delay onset of action and its efficacy. I would caution Rita that complex sleep-related behaviors, such as sleep driving, making phone calls, preparing and eating food, having sex, and sleepwalking may occur while asleep, and to inform her PCP if these sleep-related behaviors occur. I would caution Rita to avoid concurrent use of alcohol or other CNS depressants with Remeltion. And I would further educate her about the Beers criteria and the importance of avoiding Advil PM and Ambien, and consulting with her PCP before using any other medications, prescription or over-the-counter, concurrently. I would advise her to contact her PCP if signs of anaphylaxis, swelling of the tongue, throat, trouble breathing, or nausea vomiting, or angioedema, severe facial swelling, occurs.